Hello guys and welcome back to Count of 10. My name is Ani and on today's episode we're going to be starting our new series looking at renal physiology. Now, this was one of the topics that in the moment when I was going through my notes, it made a lot of sense, but when it came down to 1 or 2 weeks later, I would often find myself forgetting important concepts, going back to my notes multiple times until it sunk in. And that's why I've chosen this as our final series before I take a little break over Christmas time. Today, to get our feet wet, we're going to look at some of the more easier topics to cover, but I think also play an important role at being the fundamental topics to then when you go on and look at the big topics in renal physiology, such as glomerular and tubular function and the control of urine production. What we're going to cover today are looking at the learning objectives that cover functional anatomy, the control of renal blood flow, and the measurement of renal function. These don't have too many SAQs attached to them, so hopefully this will be a pretty quick episode. And before I get started, I just want to say a big congratulations to all the people who passed the most recent sitting. If you weren't lucky enough to pass, just a reminder, this isn't the end of the world. This is just an exam, and this is the time when you need the support people around you. So, as cliche as it sounds, make sure you take some time to just mentally offload. Spend some time with your loved ones, don't think about what the result was, and re-energize yourself to then set yourself up to give it another go. We all know how stressful this exam is, and there's lots of people that are around you that are here to support you if you need. And I just wanted to say that before we go into today's topic. So with that said, let's dive into our new series covering renal physiology.
1, 2, 3, 4.
The first topic we're going to cover today is functional anatomy. This used to have a learning objective which was describe the functional anatomy of the kidney and the urinary tract, but now it's been streamlined to just be outline the functional anatomy of the nephron. I think it's still important to have a gross overview of the general anatomy of the kidney before we dive into the functional anatomy, and so we'll start off with that with this learning objective. If you describe the kidney from a gross anatomical perspective, you can say it's a bean-shaped organ which is normally the size of a fist. It's divided into the renal cortex and the pyramids, aka the medulla, and it's surrounded by a fibrous capsule. It's a retroperitoneal structure which moves with respiration and superiorly has an adrenal gland attached to each of the kidneys. Within the hilum of the kidney, there are 3 important structures. The first are the blood vessels, the second are the nerve supplies, and the third is the ureter. Within the blood vessels, the renal arteries come from the aorta and there's a left and right renal artery. The right runs behind the IVC and the renal artery breaks into the segmental artery, the interlobar artery, the arcuate artery, the interlobular artery, the afferent arterioles, followed by the glomerular capillaries, the efferent arterioles, the peritubular and the vasa recta, the interlobular veins, the arcuate veins, and then the interlobar veins which go into the segmental, followed by the renal veins. The left renal vein has a longer tract going back to the IVC, and the unique feature is that it also has the gonadal vein attaching to it on the left-hand side. Within this description of the blood vessels of the kidney, you might have noticed there are 2 sets of capillaries. This makes this system a unique system in our body, known as a portal system. There's only a few other portal systems in our body. There's a portal system within our liver, and there's a portal system in the hypophyseal tract. And a portal system is one that has 2 sets of capillaries before returning into systemic circulation. In terms of the nerve supply, this can be broken down into the parasympathetic nerve supply, which is done by the vagus nerve to the kidney, and the sympathetic nervous system supply, which is done by the sympathetic chain, mainly the celiac ganglion, which ranges from T10 to L1. In some text, they say it's T11 to L3, but importantly, you need to know that the sympathetic nerve supply is way more prominent than the parasympathetic nervous supply. Finally, the ureter is a funnel-like structure formed by the major calyces that goes into the bladder, and you have one ureter associated with each kidney. That's a brief summary of the gross anatomy of the kidney, which allows us then to move into the functional anatomy of the kidney. And when you think about the kidney as a working tissue, you can divide it into the cortex and the medulla. And within these two structures, they're made up of tubules and blood vessels. And in between those two structures, we have interstitium. And the interstitium volume of a kidney is roughly around about 10%. The importance of knowing the interstitium is that within the interstitium itself are scattered interstitial cells, and these are the cells that secrete EPO. So what do you see when you look at the cortex and the medulla? The functional unit of the kidney is a nephron, and you hear that term quite often when you think about other structures. For example, the functional unit of a liver is a hepatic lobule. So within each major organ, you have a functional unit, and for the kidney, it's the nephron. So this is the thing you have to know really well. The nephron is broken up into a renal corpuscle and a tubule, and overall, it's made of a single layer of epithelial cells. When we look at the renal corpuscle first, these are only seen in the renal cortex. They're spherical filtering components where the glomerular capillaries are and the Bowman's capsule sits. Here, fluid is filtered by opposing hydrostatic and oncotic pressures, and we'll talk about this in our next episode when we look at glomerular and tubular function in more detail. In terms of a gross overview, the glomerular capillary is an endothelium structure which has fenestrations that allow passing of solutes into the Bowman space. The Bowman space is contained within the Bowman's capsule, and the Bowman's capsule has within it an endothelium layer, a basement membrane, and a capsular epithelial cells, aka podocytes. And you would remember hearing about podocytes when we talked about the blood-brain barrier. Remember, podocytes have foot processes so that not all substances can pass. And this is just another way of allowing selection of only certain things to be filtered from the renal corpuscle into the tubule. The other types of cells that are associated with the renal corpuscle are mesangial cells. These are closely associated with capillary loops and produce some connective tissue, as well as having myofilaments that allow for contraction and relaxation, which change the area for diffusion and filtration. And this will be important to remember when we talk about renal blood flow next. If you find visualizing the renal corpuscle hard in your head, what I found the most useful as an adjunct to this was looking at Dr. Najib's YouTube videos on describing glomerular and tubular function. That's a good visual adjunct that helps you see all the components of the renal corpuscle, which are the glomerular capillaries, the Bowman's capsule, and the mesangial cells. Moving on to the tubules, which is the second component of the nephron, this is much more easier to understand because I think majority of us still remember this really well from the med school days. A tubule is the part of the nephron which starts at the proximal tubule, which consists of a straight part and a proximal convoluted tubule part. This part reabsorbs a large amount of filtrate such as water, sodium, chloride, potassium, bicarb and glucose, and the proximal convoluted tubule feeds into the loop of Henle. The loop of Henle can be divided into the descending part and an ascending part. Within the ascending part, you have a thin limb which then becomes thick as it enters the cortex, and the descending part is a thin limb. From the loop of Henle, you have the distal tubule, which consists of the distal convoluted tubule and the distal tubule itself. Here you can have further reabsorption of solutes such as sodium, bicarbonate, calcium, but importantly, water is not reabsorbed here. Then from the distal convoluted tubule, you have the collecting ducts, which then drain into the papillary ducts, which then funnel the final urine into a series of chambers known as your calyces to then filter in through to your ureter into your bladder. So that's the basic overview of a nephron. It's made up of a renal corpuscle and a tubule. And the way we classify nephrons even further is by their location. And this is done by looking at the loop of Henle itself. We can classify nephrons as either being superficial cortical, juxtamedullary, or mid-cortical. And what that means is how far does that loop of Henle extend into the medulla. If that loop of Henle is short and doesn't go into the medulla, it's classified as a superficial cortical nephron. If it goes deep into that medulla, it's classified as a juxtamedullary nephron. And these are unique because the efferent arterioles here give rise to the vasa recta. If that nephron sits in between the superficial and juxtamedullary, it's classified as a mid-cortical nephron. Majority of nephrons are cortical, this making up 85% of nephrons, while only 15% of the nephrons are juxtamedullary, and the functions of these are also different. Typically, cortical nephrons are used more for filtration, while juxtamedullary are used more for the concentration of urine, which we'll talk about again in our subsequent episodes. Finally, to finish off this learning objective of functional anatomy, we mentioned briefly just before the vasa recta, so we need to just touch on this briefly now. The vasa recta arises from the efferent arterioles and is a low-pressure capillary system which receives a large amount of fluid and where electrolytes are absorbed. It follows the loop of Henle, however its flow is the reverse of the loop of Henle. So as the vasa recta descends, its parallel is the ascending loop of Henle. And as the vasa recta ascends, its parallel is the descending loop of Henle. What this is important for is what we describe later on as the countercurrent mechanism, which is important for transforming glomerular filtrate into concentrated or dilute urine. Again, we'll talk about these complex concepts in our next episode, but it's just important to get your mind thinking about this, and this is why I say these topics here are kind of like the fundamental stepping stones that you need to then be able to understand the complex stuff later on. The last functional anatomy thing we should touch on, which is very unique to the kidney, is this thing called the juxtaglomerular apparatus. And this is formed where the ascending thick loop of Henle passes the afferent and efferent arterioles close to the glomerulus. There are three components of the juxtaglomerular apparatus. Firstly, the granular cells, which produce and store renin. Secondly, the macula densa, which are morphologically distinct area with cells that are in close contact with the mesangial cells and the granular cells, which are involved in the renin production. And then finally, the mesangial cells themselves. And you'll understand why I bring this up, as it segues nicely into our next learning objective, explain the physiology of renal blood flow. When we describe renal blood flow, it follows the same laws to any organ blood flow, where flow is equal to the change in pressure over resistance. Normal renal blood flow is 20% of the cardiac output, which in an average adult is 1 liter per minute. This can be further indexed to say it's 400 mL per 100 grams per minute if we say that each kidney weighs an average of 150 grams in an adult, which is actually just 1% of total body weight. The oxygen extraction of the kidney is 10% of the O2 that's delivered to it, and there's a key difference in the blood flow between the cortex and the medulla, and this is why renal blood flow is usually a pet favorite when it comes to a Viva topic. It's a really important point to know, and that is that the cortex receives 90 to 95% of the blood flow, but the blood flow here doesn't match the metabolic demand. The cortex does little work, but the blood flow is needed to produce the filtrate that goes through the nephron, and really the blood flow here is trying to maintain the GFR. While in the medulla, it receives only 5 to 10% of the blood flow, but it has a very high metabolic demand and a high oxygen extraction ratio, and the blood flow here needs to be low to achieve the goals of the medulla, which is to facilitate either the concentration or the dilution of the urine itself. The clinical implication of knowing this distribution of blood flow between the cortex and the medulla is that the medulla itself is now susceptible to ischemia in shock states. Because the primary goal of having high blood flow into the kidneys is to drive the filtration, there is very little autoregulation of the juxtamedullary nephrons, and this means that any kind of low blood pressure or decrease in blood flow leads them really susceptible to ischemia, and that's typically why you see patients that are unwell with an associated AKI. In terms of raw numbers to remember, the oxygen demand of the kidney is 6 mL of oxygen per 100 gram per minute, so therefore it's equivalent to 18 mL of oxygen per minute. Looking more at the control of renal blood flow, you have to go back to remembering what is the goal of renal blood flow, and it's really two reasons. It's to maintain a GFR and to maintain sodium reabsorption. If GFR is increased too much, it will overwhelm the capacity to reabsorb sodium and water, and if GFR is decreased too much, then there'll be insufficient excretion of waste substances. So therefore, the most important factor to changing GFR is changing renal artery pressure. Within the glomerulus, you have these two stop filters. You have the afferent arteriole and the efferent arteriole. Because they lie in series, their resistant effect is additive, and these are the chief sites of resistance where flow can be changed. If you think about it in a healthy adult, a map of 100 or 90 is normal. This is entering the afferent arteriole. The pressure drops here to 60 millimeters of mercury, and by the end reaching the efferent arteriole, leaving into the peritubular capillary, the pressure is dropped to 20 millimeters of mercury. And you need that pressure drop to allow time of filtration to occur appropriately. Again, we'll talk about this a lot more when we talk about glomerular and tubular function, but this is a very important concept to just keep hammering home. The mechanism of action of how renal blood flow is kept constant is mainly through autoregulation. And remember, every organ has a degree of autoregulation. The autoregulation range for renal blood flow extends from 70 millimeters of mercury of MAP all the way up to 170 millimeters of mercury of MAP. And this is why we say in chronic hypertensive patients that autoregulation zone might be shifted to the right. So instead of targeting a MAP of 65 in a really sick patient, you might be targeting a MAP of 70 or 75 if they have a degree of pre-existing chronic hypertension. The two ways that autoregulation is achieved in the kidney is firstly by myogenic regulation, and this is the main way autoregulation is achieved, and myogenic regulation involves the afferent arterioles only. What happens with this regulation is that in response to stretch, the vascular smooth muscle of the afferent arterioles constrict, decreasing renal blood flow and decreasing GFR. The opposite will occur with decrease in stretch. It's a rapid process that takes seconds, and the exact mechanism of action is unknown. It's thought to be underlying due to membrane depolarization, but you don't really need to know much more than that for myogenic autoregulation. The second way autoregulation is achieved, and this is the unique way to the kidney, you need to know this well, is the tubulo-glomerular feedback mechanism. And this is why we previously ended the last learning objective talking about the juxtaglomerular apparatus. This unique mechanism of the kidney relies on the apparatus, specifically the macula densa, to measure the composition of sodium and chloride in the ascending loop of Henle via the sodium-potassium 2-chloride cotransporter. If there's high sodium and chloride, this means that the kidney is having a high GFR, which therefore means that the renal blood flow must be high. If there's a low sodium and chloride, this means that GFR must be low, and therefore the renal blood flow must be low as well. So in response, if there's high sodium chloride, the macula densa release adenosine. This is done really fast, and this will constrict the afferent arterioles. The constriction of the afferent arterioles will lead to decreased blood flow going into the glomerulus, and therefore it will decrease the GFR and decrease the concentration of sodium and chloride. In opposite function, if the sodium and chloride is low, the macula densa will release nitric oxide, which will vasodilate the afferent arterioles, increasing renal blood flow, increasing GFR, and increasing the concentration of sodium and chloride. Very rarely, if you're doing really well in a viva, they'll ask you to say what compound causes this response. So remember, it's adenosine and nitric oxide, and it's acting uniquely and only on the afferent arterioles. Now, autoregulation isn't the only way that renal blood flow is changed. There is also extrinsic control of renal blood flow, which can be broken into two components. There's the effect of circulating hormones, and then there's the effect of neural control itself. Within circulating hormones, the important hormones to know of are angiotensin II, which both constrict the afferent and the efferent arterioles, as well as cause the mesangial cells to constrict. There's the effect of eicosanoids, such as prostacyclin, PGI2, PGE2, which are locally active vasodilators and are important in high states of vasoconstriction so that renal blood flow doesn't decrease too much. That's why you typically avoid giving nonsteroidals in patients with acute renal failure. Then you have ANP, which dilates the afferent arterioles, increasing renal blood flow, therefore increasing GFR and increasing urine output, which is typically in response to a hypervolemic state. And then you have the effect of renin, which is released by the juxtaglomerular apparatus. Then you have neural control, which is mainly driven by noradrenergic sympathetic stimulation. The unique thing about neural control is that it constricts both the efferent and afferent arterioles. However, the effect on the efferent arteriole seems to be way more pronounced than the effect on the afferent arteriole. And this has an implication on not just renal blood flow, but also GFR. With neural stimulation, you don't seem to get as much of a decrease in GFR, and this is because while the renal blood flow is decreased, because the constriction in the efferent arteriole is greater than the constriction in the afferent arteriole, GFR seems to be less affected than renal blood flow is. So overall, with sympathetic stimulation, in normal conditions, there's only a slight net decrease in GFR. However, when you get in disease states where you might have a massive sympathetic surge, that sympathetic surge, unlike in normal conditions, is enough to decrease renal blood flow to a point where you start to get ischemia and AKIs occurring, which also then have a negative impact on decreasing GFR subsequently. Now, this is a broad overview of renal blood flow, and it's a lot of important concepts to get for the first time. Remember that renal blood flow is mainly there to drive GFR and to facilitate reabsorption of sodium. Typically, renal blood flow and GFR are coupled and are regulated by changes in tone of the afferent arteriole, and this can be done through autoregulation, either myogenic or by the tubuloglomerular feedback mechanism. Renal blood flow is more precisely regulated than GFR, and we know this because with sympathetic stimulation, the efferent arteriole is constricted more than the afferent arteriole, and while renal blood flow decreases, GFR doesn't decrease in the same linear fashion. And this means that when we draw a graph which has on the y-axis GFR and renal blood flow, and on the x-axis has MAP, we know that the autoregulation range for renal blood flow is between 70 millimeters of mercury and 170 millimeters of mercury. And within this range, renal blood flow is constant. However, GFR in this range is not constant. There's a slight increase as renal blood flow increases that GFR increases as well. And then sometimes with this graph, you also see urine output. And urine output kind of linearly increases until you get past the point of the 170 millimeters of mercury autoregulation, and then it just exponentially increases. And this happens because of a concept known as pressure diuresis. This I found was a bit hard to explain, and I never really got asked it in any viva form, but my very simple explanation is that in the juxtamedullary nephrons, there is no autoregulation that occurs. Therefore, when there's an increase in blood pressure, flow is diverted from the cortical nephrons into the medullary nephrons, and with this, you get a greater washout of things like sodium, chloride, urea, and a decrease in our concentration ability of those juxtamedullary nephrons. And therefore, you get an increased urinary loss of water and solutes known as pressure diuresis. So once you pass that point of the superior threshold of renal blood flow autoregulation, you can get an increase in diuresis due to a flow diversion into your juxtamedullary nephrons. And again, this hopefully shows you why there's an importance of knowing the functional anatomy to then understanding these concepts of blood flow and filtration. This moves us on to looking at our last topic for today and our last learning objective, which is measurement of renal function. The learning objective here is describe the principles of measurement of glomerular filtration rate and renal blood flow. Starting off with how we go about measuring GFR. GFR is the measurement that's determined by the clearance of a substance that is freely filtered from the glomerulus, neither secreted nor reabsorbed in the tubules. It must not be metabolized or stored in the kidney. It must not affect renal function, and it must not be excreted extrarenally. So with those parameters set in place, GFR is actually quite a hard thing to measure. We can measure it either by trends, looking at endogenous substances that most fit that criteria, or we can use formulas that give us an approximation of GFR. The only way to accurately measure GFR is in research settings with the use of exogenous substances that meet that criteria that I previously said. And the two exogenous substances that you need to know of are either inulin or radiolabeled molecules. Inulin is a small sized particle which is around about 5,000 Daltons, which meets all those previously mentioned criteria. However, the reason you can't use this clinically is because the measurement requires a long process, as it needs an infusion to reach a constant plasma level before it can be measured. So what we do instead clinically is either use common endogenous substances to predict what GFR is, or use formulas. The two endogenous substances that you would have seen the intensivists really pay attention to is either creatinine or urea. Creatinine nearly meets all the criteria to measure GFR, as it's freely filtered from the glomerulus. However, there is a small portion which is also secreted into the lumen, and this means that the measurement is an overestimation of GFR ever so slightly. The other issue with creatinine, its amount can be affected by muscle mass as well as renal blood flow. In terms of renal blood flow, the easiest physiological state to remember is in pregnancy. In pregnancy, you have a higher renal blood flow, and therefore the normal baseline creatinine levels drop compared to the non-pregnant person. In terms of muscle mass, a person with higher muscle mass or lower muscle mass will alter the normal level of creatinine. Therefore, a normal level of creatinine can sometimes mask an underlying renal injury. The second endogenous substance we have is urea. It's not as good of a measure as creatinine. Although it is freely filtered, 50% of it is reabsorbed in the proximal tubule. Urea levels also depend on the activity of ADH, and it's a nitrogenous waste product, and therefore its plasma concentration depends on protein intake and metabolism. So then what are the alternative formulas that we have that can help predict GFR? The best formula that we have is the Cockcroft-Gold formula. This formula estimates GFR using an equation which uses age, weight, and the patient's plasma creatinine level to then give us an estimated GFR. And normally we say that a GFR greater than 90 mL per minute is a normal reference point. But just remember that GFRs greater than 90 mL per minute is the criteria for stage 1 chronic kidney disease. When you're using the Cockcroft-Gold equation, what you see is this clear inverse proportional relationship between creatinine clearance and plasma levels. As creatinine clearance increases, the serum creatinine levels drop, and this is an exponential relationship. However, with this formula, there can be inaccuracies, especially in patients who are obese or have extremes of body composition. That's why we say with any of these tools that are trying to give us an estimation of GFR, it's not just a single value that you're looking at, it's more importantly the trend of those values that you're paying a bigger attention to. This moves us on to now look at renal blood flow and how we measure this. But it's not so much renal blood flow we want to measure, more so renal plasma flow, because it's the content in the plasma that's going to be filtered, secreted, and then reabsorbed. So when we look at renal plasma flow, we know that the normal blood flow to the kidney is approximately 1 litre per minute, which is 20% of the cardiac output. If we say that the normal hematocrit is 0.4, then out of that, 600 mils a minute is the plasma flow that's going through the kidney. So this is the baseline renal plasma flow. But not all of this 600 mils gets filtered through as GFR. Only 20% of the delivered plasma forms the glomerular filtration rate. So therefore we say that the normal filtration is approximately 125 mils per minute. The remainder 80% of the plasma then enters the peritubular capillaries. So this is important to understand because we're now saying instead of measuring renal blood flow, we're going to try to measure renal plasma flow. And if renal plasma flow is normal, then we can say you have a relatively healthy kidney. If renal plasma flow is decreased, this is a sign that your kidney is having deterioration and you're going into either acute or chronic renal failure. So then how do we measure renal plasma flow? From my understanding, this is all a bit theoretical and not really used in clinical practice. The common substance used is something called para-aminohippuric acid, or PAH, and at low plasma levels, virtually is completely cleared and approximately 90% is excreted in the urine. Therefore, we can use it as an approximation for renal plasma flow, with the equation being that total renal plasma flow is the effective renal plasma flow divided by the extraction ratio. And if we say that the effective renal plasma flow is approximately 600 mils per minute and the extraction ratio for PAH is 0.9, then we can say that the total renal plasma flow is approximately 650 to 700 mils per minute. We can also reverse engineer this equation to help us give us the number of what renal blood flow is. The equation for just renal plasma flow is 1 minus the hematocrit times the renal blood flow. So if this is just simply rearranged, then renal blood flow is the renal plasma flow divided by 1 minus the blood hematocrit. And if you put the numbers in for this, you get roughly 1000 to 1200 mils per minute, which is what we know as a normal cardiac output going to the kidneys. Now, I was never asked how to calculate renal plasma flow in any of the vivas that I got, but it's just something to have in the back of your mind because it is part of the learning objective. And it's not been asked specifically in any SAQ that I can find. This brings us nicely to look at the past SAQs on the topics we've covered today, and there really aren't that many to go over. There are really only 2 SAQs I want to go over from the past exams, and the first one covers renal blood flow. There isn't any ANSCA past SAQs that have been asked on functional anatomy, but there has been a question regarding functional anatomy in the KICM exam in 2019. This question was, outline the functional anatomy of the kidney, 40% of the mark, and outline the regulation of renal blood flow, 60% of the mark. In 2018 first sitting, in our exam, we were asked to discuss the determinants of renal blood flow, and this had a poor pass rate of 32%. You could see how this question could be asked again with that variation that was asked in the KICM exam. And as per the examiner report in the KICM exam, what was expected for the first part within the functional anatomy was a description of the nephron, the description of different nephrons in the cortex and the medulla, the innervation to the kidney, and the blood supply to the kidney, which is what we covered in the gross anatomy at the start of this episode. Remembering broadly that the kidney is a retroperitoneal structure, which is roughly 150 grams each. It has an outer cortex and an inner medulla. The medulla have pyramids, and these are then connected to the collecting ducts, to the ureters, and then the bladder. The blood supply needs to be divided into the arterial and the venous blood supply, with the arterial coming from the renal artery, the interlobar, the arcuate, the interlobular, the afferent and the efferent arterioles, the peritubular or the vasa recta, and then the reverse order with the venous system. The nephron is the functional unit of the kidney, which is very important to say, and within the renal corpuscle, you have the glomerulus, the Bowman's capsule, and the mesangial cells. This can then lead on to answering the question about renal blood flow, and from the examiner report within our exam, they mentioned that the main points expected included an appreciation that the renal blood flow exceeds metabolic demand for the purpose of a high glomerular filtration to regulate body fluid volumes and solute concentrations. Additionally, they specifically said you could get additional marks for demonstrating an understanding of how autoregulation worked, both myogenic and the tubular glomerular feedback, and this could be integrated into the RAS system, of which little detail was expected. Within this question alone, you didn't get any marks for talking about the anatomical flow pathways, and a common error was not understanding what mechanism of the tubular glomerular feedback system causes what response in the afferent arteriole in response to the change of the sodium chloride concentration. So in my model answer for this question specifically from the Ansky exam, I would omit talking about the anatomy because they've mentioned specifically it's not needed in the examiner report. I would just start off with what normal renal blood flow is, which is 20% of the cardiac output, 1 litre per minute, and approximately 400 mL per minute per 100 grams of tissue. The other important point I'd put next to this is that the cortical blood flow is much higher, and this is approximately 90% of the blood flow. And if you look at the ketamine nightmare numbers, it's roughly 500 mL per minute per 100 grams of tissue, while in the medulla, this is down to 20 mL per minute per 100 gram of tissue. The opposing factors is that the extraction ratio of oxygen in the cortex is 0.2, while the extraction ratio in the medulla is 0.8, and this is because of the differing roles, and I would specifically say that because it's an important distinguishing factor that the examiner report wanted. And this is how I would link in my next part, which is the autoregulation and the determinants of renal blood flow. Renal blood flow can be described by Purcell's equation, where it is the change in pressure as a numerator divided by the resistance. And because we're saying this is Purcell's law, resistance is going to be the biggest factor. So the biggest factor that's going to affect resistance is myogenic autoregulation. If you want to put in the diagram of autoregulation between 70 to 170 MAP, you can, but I think it's just easier to write down rather than having to describe it. This links on to describing what myogenic autoregulation is, and that is that the flow is kept constant via change in the afferent arteriole vascular smooth muscle, whether it's being constricted at high flow rates or dilated at low flow rates to maintain a plateau of renal blood flow across a wide range of blood pressures. Then you have to put in the specific autoregulation which is unique to the kidney, and that is the tubular glomerular feedback. This is done at the juxtaglomerular apparatus, and it's a recognition by the macula densa which measures the sodium chloride composition. If the sodium chloride is high, this interprets it as a GFR is high, and therefore the renal blood flow is high. Consequently, adenosine is released to vasoconstrict the afferent arteriole. If the concentration is low, then nitric oxide is released, which vasodilates the afferent arteriole that leads to an increase in renal blood flow, an increase in GFR, and a normalization of the sodium chloride concentration measured at the macula densa. Then you have the extrinsic control of renal blood flow, which can be broken down into the effects of the circulating hormones or the effects of the neural system. The main hormonal system is your RAS system, with the end product of angiotensin II having the biggest effect. And from a renal blood flow perspective, the effect of angiotensin II is to constrict the efferent arteriole more so than the afferent arteriole. This leads to a decrease in renal blood flow, but an increase in GFR. While the secondary effects of angiotensin II, which is the increased reabsorption of sodium and water, will lead to an increase in blood volume, which will increase the mean arterial pressure, which will improve renal blood flow. The other hormones that are circulating are your ANP, which is going to vasodilate the afferent arteriole, increasing renal blood flow, your prostaglandins, which are protective, and they're going to vasodilate again your afferent arteriole, increasing renal blood flow. And then you can go on to your neural effects. Within your sympathetic nervous system, we already touched on this, how this is going to lead to an increase in efferent arteriole vasoconstriction. So while you have a decrease in renal blood flow, your GFR is generally preserved or decreased ever so slightly. And this is the part that I found really tricky to always understand, because while renal blood flow is decreasing, Sometimes this is decreasing your GFR, and sometimes this is keeping your GFR the same. And it really depends on how the blood is flowing once it goes past the afferent arteriole and before it exits out of the efferent arteriole. If that time course stays the same, then generally the GFR is unchanged. If that time course is minimized, then the GFR will generally decrease. And if that time course is lengthened by increasing the efferent arteriole vasoconstriction even further, then the GFR will generally increase. But I'm probably focusing too much on GFR rather than just focusing on answering renal blood flow and what happens with that with this question, because that's what's specifically being asked. If you're struggling to still answer this question, I personally think the Propofol Dreams answer is a really good summary of some of these complex relationships between renal blood flow and GFR, and it's summarized quite well, and it has a rationale for why they've given their model answer. Moving on to the last SAQ, which was asked in 2019 in the first sitting, and this was an SAQ that covered the measurement of renal function, which was outline the clinical laboratory tests of renal function and what are the limitations of each test. This had a 54% pass rate, and within the examiner report, the key things they wanted mentioned was a discussion of plasma creatinine, plasma urea, and creatinine clearance as estimates of glomerular filtration rate. The common issues as per the examiner report with this question was it seemed that people struggled to understand that excretion of waste products was a key function of the kidney, and an inability to excrete these certain waste products could then be used as a marker for renal dysfunction. Another source of error was inadequate explanation about the relationship between plasma creatinine concentration, creatinine clearance, and GFR, and that some people were unaware that you could estimate GFR using a formula derived from population data, which does have some limitations associated with it, but can be used, and this is the Cockcroft-Gold equation. So to answer this question, I would start off with a generic statement to say that renal function can be approximated by the function of the glomerular filtration. The ideal clinical laboratory test that would allow us to monitor renal function would include a tracer that was freely filtered, not reabsorbed or secreted or metabolized, and that the clearance of this substance would then estimate GFR. However, there is no substance that meets this ideal requirement perfectly. Therefore, we can use either plasma markers, formula equations, or, in research setting, exogenous substances. Within plasma markers, you have to talk about creatinine and you have to talk about urea. With creatinine, the things I would make sure I say is that it's freely filtered, but 10% is secreted. It comes as a metabolite from muscle cells, and therefore it can be either overestimated or underestimated depending on muscle mass. In contrast with urea, urea is also freely filtered. It's an end product of amino acid breakdown. However, 50% of the freely filtered urea can be reabsorbed at the proximal tubule. It can also be secreted in the descending loop of Henle and then reabsorbed in the medullary collecting ducts. The main issue with urea is that it can vary depending on the patient's dietary intake, as well as the patient's protein metabolism and their level of hydration. There's a nice graph on ketamine nightmares that sometimes gets shown in a Viva setting, and that is you need more than a 50% decrease in GFR before you start to get significant increases in plasma creatinine and urea levels. So that means that the kidney has a huge buffering capacity and that these estimations are very rudimentary. So clinically, the most important thing to say is that one-off values do not indicate renal function, but rather a trend of values gives a better clinical picture of renal function. You can also use the urea to creatinine ratio or the Bunn ratio, which can help you determine whether renal injury is either pre-renal cause, intrarenal cause, or post-renal cause. Then you have your formula estimations, and the one we talked about was the Cockcroft-Gold equation, but there are other equations that can be used. The main issue with these kind of formulas is that in specific populations like elderly or in pediatric population, they can't accurately give you a GFR. There's also issues at extremes of body weight, and it's an equation that's standardized based on its population from the original study. Finally, you have the exogenous ways you can measure GFR, and I've never seen this done clinically, so I assume this is all done in a research setting, but you can use the markers like inulin or radioisotopes that we spoke about to then give you the most accurate GFR reading. With inulin, it's the gold standard. It's freely filtered, it's not secreted, it's not reabsorbed, it's inert, and it's non-toxic. But the problem is that it's invasive, it requires an infusion to reach steady state, and this requires time. And that's really all I'd have the mental capacity to cover with this type of question. And I'd hope that that's enough to get a pass mark. So then that brings us to the end of our first topic in our renal physiology series. And hopefully we've laid some fundamental groundwork to help us understand the more complex topics that are going to come up. Like I said at the start, it's one of those topics that when I read it in the moment, I seemed to understand, but it was so easy to forget even 1 or 2 days after I had read it. And even then, I found it really tricky. So hopefully by the end of this series, you'll have a good platform to go back to. And with that said, I'll leave it there, guys. Thanks again for listening, and I'll catch you guys next time on Count to 10.